I'm here with Dr. May Bakir, and she is a cardiologist who I found on Instagram. Like so many women these days, I'm getting most of my information from doctors on Instagram because we're not being told other things in our regular practices. And what really interested me is what you said in a recent Instagram post, which is that GLP-1s are heart medication. Now, I will tell you why I'm interested in that, because I went to a women's health summit back in February, I think it was, or maybe March. And there were two doctors there out of the six that spoke. One was a OBGYN and the other was an obesity medicine specialist. And both of them said that menopausal women gaining belly fat, which I was doing at the time, I had gained over the course of 2 years. I went from 112 pounds, which I've been my entire life, except for during pregnancy, to 130, which is not a lot. It's still, the BMI is fine, but it wasn't me. Yeah. It wasn't my body. And all the fat was coming into the belly, where I know that's visceral fat. So I was listening very intently. And then for example, just last weekend, the New York Times came out with an article about how inflammation is everything, and it's related to cancer. It's related to cardiac.
Yeah.
Tell me what you do in your practice.
Well, in my practice, we look at everything. So I think that in our traditional healthcare system right now, organ systems are siloed out, very much so. So even if you're seeing a cardiologist, it might be the electrophysiologist who's the electrician of the heart and looking at arrhythmias. And they won't look at your cholesterol. They won't look at your blood pressure. And I think that's missing the point, right? Because everything works together. And so our organs cannot be siloed out, and they can also be separated from our family history, our personal history, our lifestyle. And so my practice really takes this approach of, we want to optimize cardiovascular health, cardiometabolic health, heart and hormone health, and lifespan issues. So sleep, bones, etc. And it's all important because they all are interconnected. And when we try to just, distill them is when you get this fragmented care. And we know that right now, 1 in 3 people lives to be 105. And by 2030, 105, right now 103. And the Lancet came out earlier this year saying that by 2050, 1 in 3 people will be living to 115. I don't care so much about that number. I care about the quality of life.
That's what I want to talk about too. It's that, all these men that are saying they want to live forever, that's not my desire. My desire is to live well during the years that I have. And I think, I don't know, I'm not going to speak for all women, but I think a lot of women that I speak to feel the same way.
Exactly. And I think that you hit on something too, is that you did nothing differently, and yet everything changed. And it was
immediately at 58, immediately.
And so, the part of it is that for women's research, health research, we are woefully behind the 8 ball. And it wasn't until 1993 that women were even put into protocols for research. It wasn't until the early 90s that the NIH even funded any cardiovascular research. And so we still have a lot of catching up to do. That being said, we are 52% of the population. And so I know that menopause and perimenopause is having a moment, and I certainly hope it's just not a moment. It needs to be so much more than that. And hormones affect women throughout their life. So for me, as someone who's done extra training in women's cardiovascular health, I've been dealing with, cardiac obstetrics and postpartum issues, perimenopause, menopause, breast cancer, autoimmune issues that all can be affected by hormones and can exacerbate certain things. So I think
let me just break in here for 1 second to say that I got my uterus out when I was 46 because of adenomyosis, 16 years of adenomyosis, by the way, which is another issue of a metabolic issue, right?
Right.
Nobody told me to go on hormone therapy after that. Nobody told me anything. And I was suddenly having tachycardia. So I went to see a cardiologist.
Right.
she did not say to me, she did not ask me anything about what age I was, what my uterus was doing, whether I had one. I actually said, could this be menopause? And she poo-pooed it. And this was back like 10 years ago. I mean, no, I'm 60 years old. Like, it was almost 14 years ago. But to be dismissed like that by a cardiologist, asking, could this be menopause related? Could this be because I lost my uterus? Could this be because I don't have estrogen anymore?
Right. That's not taught in medical school, again, because this is just not part of the curriculum. We do have some trailblazers who are putting it into curriculum. Even for OBs, it's not taught, right? And, you know, many women rely on their obstetrician for their care. And then we saw, you know, blood pressure being untreated and so many other issues being untreated. To me, the kicker is, I think that cardiology, cardiovascular disease, obviously nobody wants it, but we have bad PR, right? Because most people will have some form of it in their lifetime, and 90% is preventable. And if you are aggressive about prevention, you can say with over 97% certainty, if you get to certain markers, that you'll never experience a major adverse cardiovascular event, meaning heart attack, stroke, hospitalization, untimely death. And my prerogative is to get women and people to know that that is in their power, that they can advocate for themselves and be really aggressive with prevention. But you're right. It is, you got poo-pooed by a female doctor, a female cardiologist, but that's because she probably didn't know. And instead of saying, I don't know, she just said no. And
right. Well, and then to be fair, very recently, I went to an amazing cardiologist who was unfortunately in the Northwell Health organization. And suddenly my health insurance, Fidelis, literally the day after our amazing first meeting, was like, we don't speak to Northwell Health anymore. So I find a good cardiologist who is informed about women's health and is informed about GLP-1s as well. And now I can't see her anymore. So in a sense, reaching out to you over the internet is me saying, I feel like women are not getting this information. We're not seeing specialists who have this broad understanding of the way, I'll go even further than this. I asked her permission. What would you think about microdosing a GLP-1 for me, which would be not the normal dose? I don't need to lose a lot of weight. Right. I'm worried about inflammation because my grandmother died young at 67 of a heart attack. My other grandmother, also young, had a pacemaker put in her 60s, died at a normal age, but had a pacemaker. My dad had cardiomyopathy. My grandfather dropped dead of a heart attack in his 70s. And my other grandfather also died eventually of heart disease later. And, my mom also has heart issues. So I have heart disease all throughout my relatives.
Right.
And I don't want to have the kind of inflammation, and belly fat does lead to the inflammation that leads to heart disease. And my numbers, my blood work was going in the wrong direction.
Right.
So I got her permission.
Yeah.
Have microdosed GLP-1 now for 4 weeks.
Right.
The tirzepatide.
Right.
And I cannot tell you, I have more energy.
Yeah.
My toe, which had terrible arthritis, doesn't hurt anymore.
Yep.
Talk to me.
There's so many things I want to say about what
I know. I gave you too much at once. Sorry.
No, but that's okay. I think that, again, this goes to the way we're delivering healthcare in this country. We have these amazing physicians, amazing science, but then not the time to discuss it. And then healthcare insurance companies and private equity are calling the shots. They were supposed to be helping people and they're not. You found this great doctor.
Yeah.
Oh my goodness, now I can't see them. That hurts, right?
Yeah.
And so, and even when it comes to representation matters. When I finished my training in women's cardiovascular health and went to Mount Sinai Heart, my own colleagues were poo-pooing the fact that I did extra training in women's heart disease. And it wasn't until I was leaving it was en vogue and everyone wanted a women's heart center. And so if they had a female cardiologist, all of a sudden they had a women's heart center, even if that female cardiologist did imaging or heart failure and had didn't have that training. And that's a problem too, because I think, well, when I was in training, it was 12% of cardiologists were female. I think it might be a little bit higher now. But for those of us who are doing extra training in women's cardiovascular health, less than 1%. Those of us who are practicing it, even less.
Wait, less than 1% of women in cardiology, which already is 12% of all cardiologists,
for sure,
are knowledgeable about women's health.
Well, I think that, it's a self-directed thing. So are you going to do an extra fellowship training? Are you going to take the courses? There's, Emory has one, Cedars-Sinai has a program, and these aren't part of the well-established heart failure imaging intervention. And so, yeah, it's a very, and I could probably list them all off the top of my head because we all know one another.
Right. Wow.
And so that's a problem. But then also, just that representation of being someone who's gone through something, and so that they can understand what you're going through, right? So then they can connect the dots and say, yeah, actually, maybe this is, the fact that you're going through menopause and perimenopause and whatnot. But then the other thing is that you were saying so much there, right? You have this family history. You have what you're experiencing right now. And that is important. Personalized care is very important. And we're getting the prevention piece slowly but surely. But getting that personalized prevention very much matters because our data comes from population studies, which are really important. But at the same time, there's nuance within that, right? So You have this grandfather who had XYZ, you had your mom and your dad, and everyone had some type of cardiovascular event.
Yeah.
And so for me, it wouldn't be just looking at the numbers. And, obviously I don't want to overstep because I don't know about your whole history.
Right.
But I would want imaging. I would want some imaging. I would want to see what your CT coronary calcium is. I would want to see the expanded panels of lipoprotein little a and apolipoprotein B to make a decision because GLPs are great medication. And I'm going to talk about them in the sense of you mentioned inflammation. So long before there was Ozempic, I was prescribing GLPs. Pharmacists would call me and say, why are you giving this patient this medication? They are not a diabetic. But I was following the data and good data because it's a problem if you're following bad data. And we knew and we saw that it helped with diastolic dysfunction and peripheral arterial disease and so many other things. Now, I want to say that, yes, inflammation absolutely matters, but Novo Nordisk just announced a very negative study that they had. They spent millions of dollars over 4 years, and it was to target IL-6 and high sensitivity CRP. And the drug did exactly what it's supposed to do, and it lowered those numbers. But what did it not do? It did not reduce heart attack. It did not reduce stroke. It did not reduce hospitalizations or that what we call MACE, major adverse cardiovascular event. And so, but the GLPs have been shown independent, and this is very important, independent of weight loss, have been shown to have a 20% reduction in cardiovascular events, independent of weight loss. So if someone was given the medication for a cardiovascular picture, they are very helpful. And why is that, right? Because they're not just addressing inflammation alone. They improve endothelial function, which is the lining of our vessels, and vasodilation. They do have anti-atherosclerotic and anti-inflammatory effects by reducing something called inflammatory cytokine secretion by monocytes, macrophages, foam cells, etc. They reduce oxidative stress. They inhibit the vascular smooth muscle from proliferation, amongst other things. And they also have this favorable risk factor modification. So they are shown to lower your systolic blood pressure modestly, but they do,
right. And by the way, my blood pressure also in the past 2 years has gone up to the point where it used to be 90/60. I had a very low blood pressure. And now I'm seeing readings of 137/90, 146 over whatever. Like it was crazy. And it just suddenly, no change in diet, actually The only change was that I was exercising more. I was lifting weights 3 times a week because I'd been diagnosed with osteoporosis. So the only change was I was actually being more healthy.
So, and that's, that's interesting because we do want to see this full picture, right? We want to see walking, that aerobic exercise. We know it doesn't help you lose weight, but why does it protect your heart and your brain? Because of the little vessels, right? So little vessels, and people don't always know this, they supply 60% of the blood supplied to the heart and to the brain. So we want and need our heart rate to go up in order to adequately perfuse those little vessels, meaning get enough blood supplied to those little vessels. Each red blood cell carries 4 atoms of oxygen when you're at sea level. And that oxygen is what maintains the health of tissue. And so that is why walking at a brisk pace, and people will always say, well, what's the heart rate? What's the target heart rate? No, we are not robots. There are some days we feel good and some days we feel a little more sluggish. You want to be able to walk at a pace where you can maintain a breathless conversation. Too chatty, too slow, can't talk at all too fast. And so all of this and bone health, so it's so important. 1 in 3 women will have a pathological fracture. The morbidity and mortality after that within 5 years is over 95%.
Yeah, no, I know.
It's not acceptable. And so, we're to look back at the GLPs and just comparing it, just to backtrack a little bit.
Sure.
But the GLPs do reduce high sensitivity CRP and IL-6, those inflammatory markers, but they don't do it. They don't only target those things, right? So you are getting a medication that's targeting so many things, including myocardial effects, right? So the GLP-1 receptor, the mRNA is present in the heart and in the sinoatrial node, which is basically what we call the pacemaker of the heart.
Right.
Okay. Native GLP-1 improves the pump function, the LV function of our heart. And so all of these things really, that is why you get this, I'm starting to feel better. And that's why numbers are looking better. But what I do caution people on is that if they have a cholesterol problem or an atherosclerotic problem, you don't want to just use the GLP. Okay. So
you want a statin on top of that?
You want either a statin or some type of cholesterol medication that has been proven. So PCSK9 and siRNA, something. So, we know that for cardiovascular benefits, the GLP has about 6 months after your last dose. The cardiovascular benefits last 6 months. That's great. So
that's amazing.
Taking it kids these days call it microdosing, but since medications have been around, doctors have given lower doses of GLPs. I mean, the fact that you commented on your joint pain going away, I can't tell you the number of people who've told me my knee's been hurting for 15 years. It stopped.
No, I'm telling you, I went to a doctor, a orthopedic surgeon, to talk about surgery. It was so painful. I was not able to walk, and we talked about it, and he said, I don't know at your age whether we could do surgery and anything would change. You have osteoarthritis. I don't know what to tell you other than, keep moving, keep trying. And literally from the moment 4 weeks ago that I took a tiny 0.125 microdose of GLP-1, my toe stopped hurting for the first time in 5 years.
Well, and I don't want to overstate things because obviously, like I said, I like to follow good data.
Yeah.
For people with psoriasis, we've seen it go into remission, really bad scalp psoriasis. Okay. We've seen 3 studies that are showing promising effects for Parkinson's disease, that they're disease modifying. We've never had a disease modifying agent for Parkinson's. Now, again, we need much more research and studies on this. But if I have a patient with Parkinson's who also can benefit from the metabolic benefits a GLP has, and I don't see harm in giving it to them, I'll think about it more than the person who doesn't have that effect.
Well, and I also want to talk about access to this. So, for example, I did talk to my cardiologist about this. We discussed whether she thought it would be useful or not. But she also said it's not going to be covered by insurance because you're not obese. And which is so crazy that we have to be sick to get treatment rather than doing preventative treatment. But I, at this point, found, MIDI is a company for menopausal women, and they are providing, and I think it's expensive. It's like $175 a month for the microdose of this GLP-1. But at this point, I'm willing to spend that.
Right.
Because
there are ways to circumvent that are a little sneaky, but for my patients, I'll go directly to Eli Lilly that does tirzepatide. And why do I prefer tirzepatide? People will say, well, I'm going to get a compounding and I'm going to do this. The problem is that one, contamination, and two, formulation matters. Like I said, GLPs have been around for so long. Why did they become so efficacious? Well, formulation and the research. These companies spent tens of millions to Eli Lilly moved one carbon atom at a time for over 7,000 variations of the medication to see what gave the least side effects and the most efficacy. I mean, that matters, right? And so for my patients, many of my patients don't qualify for the GLP, and some, by the way, who should that don't, and then some who you think wouldn't do because, again, health insurance is being the doctor. Health insurance is playing doctor.
And by the way, had I been able to keep my cardiologist, we would have had this conversation. But I had to say goodbye to her the next day. So if you know a good cardiologist in New York City, at the end of this, we'll get off and we'll talk about that.
Yeah, absolutely. I don't know. Not all physicians know about these things unless they're really working in that area, right? And so I do think that accessibility for the GLPs will become much easier. In fact, they're trying to get FDA approval for cardiovascular benefits, which just hasn't been done yet.
Right. Well, and the other thing that we discussed with my cardiologist is that the clinical trials for this, for women in menopause, the data that we need is not going to be around for a while. But I'm going to be 70 at that point.
So I know. And that's why I say, that's why it's very nuanced, and you need someone looking at your whole picture to make you a personalized plan. For me, it's another sensitive topic, is that I'll see women and even physicians say, okay, well, I'm going to put my patients on HRT and all their numbers improve. Improving numbers does not mean reducing cardiovascular events.
Right. That's an important thing. I say that again. Improving numbers in your blood work
does not necessarily mean lower rate of heart attacks, strokes, etc. And we've been shown this over and over again. Ezetimibe, very popular drug. It does not work on its own. And it took 7 years and over 18,000 patients to see that it needed to be added to a statin or a PCSK9 to give modest benefit. It did lower LDL, but it did not lower risk of heart attack, stroke. Same with HRT. If you have a cholesterol problem, please do not use HRT as your treatment. And I'm not saying that HRT doesn't have a role. Believe me, I prescribe it to so many of my patients. It is a wonderful tool. I'm glad the black box is gone. But when you have atherosclerotic disease, treat that disease with proven medications that have the outcome data. Again, we need more research. We're all trying to participate in that research. But just following your patients and seeing, oh, but their numbers went down, you're not looking to see at those outcomes. And those outcomes are what we care about, not just making your labs look pretty. I'm not here to make your labs look pretty. I'm here to make sure you don't end up in the hospital.
Right. No, that's really, really important to say. But, also, we all have to look at our own, in terms of personalized medicine, our own personal history of inflammation. And when I thought about it in those terms, okay, I've had all these weird things. I wear hearing aids because I lost my hearing to COVID. When I was 4 years old, I had my adenoids out because they became inflamed.
Sure.
I had adenomyosis for 12 years. I had appendicitis. All of these things are inflammation related. And, I certainly never put it together. Doctors never put it together. But suddenly I'm seeing a picture of my health as every time there was a dip in that health for whatever reason, loss of hearing, adenomyosis, it's all
inflammatory and autoimmune. They go hand in hand. Absolutely. Yeah. And so that's another thing. And the other question that you need to be asking your physician and being honest with yourself about is that you need to be doing something that you actually can stick with. And so part of what I tell patients always is that we have this one life. We want to enjoy this life. And
Yeah.
so anything that we're doing together shouldn't be a burden. It shouldn't be something that weighs us down. It needs to be compatible with living a joyful life. And just to, whenever you're making decisions about your health, for it to be coming from good data and not just opinions, right?
Right.
Because that is when it gets to be dangerous.
No, absolutely. But also good data, no opinions, but also we need good doctors. I mean, finding you is a miracle to me. There's just not that many women who are cardiologists who are knowledgeable about women's bodies that have only been studied since 1993 anyway.
Yeah.
So you're a unicorn, right? And we need more unicorns out there.
We need more
I mean, it's like my daughter, when I dropped her off to med school, I said, just make sure you learn something about menopause because
yeah. I mean, right now, to learn something about menopause, you have to go through the American Menopause Society. It is not in curriculum. That is a problem. That is a problem. And the other thing is just that we need people. Harvard came out with this study several years ago, back actually around 2014, 2015. And it was done by male physicians. And it showed that if you had a female physician, you not only lived longer, you lived better. I thought this was common sense, but my male colleagues were outraged. And then did the study, okay, and that came out maybe 2 years ago. And it reinforced those results. Not only do we do exponentially better for our female patients, we actually do significantly better for our male patients too. And two reasons for that. We follow the science, we follow guidelines, and we listen.
Yeah. No, absolutely. And listen, the same day that I lost my cardiologist, I also lost my beloved urologist who has been with me for 4 years now. And so I had to find a new urologist that would take my insurance. And I'm telling you, it was like a 3-day quest to find one. I finally found one. And, the first appointment was in December. I was like, I'll take it. This is the issue with women's health right now, is that we know those of us who've been in this, on healthcare journeys, and I've been on quite a few, we know that the women that we see are much more empathic and will listen to exactly what we're saying, not try to sort of make some overarching statement that is based on their knowledge of male bodies, but an individualized statement based on our specific body.
Right. No, and that, God, it really does matter. And the health anxiety that is tied into all of this, that's just dismissed, and to be able to not just hear a patient and treat them, but to relieve that anxiety, because it doesn't need to be there.
Right. Well, listen, I really appreciate, I know you're a busy doctor and I've taken already a half hour of your time. If there's anything I haven't asked you about heart health and women, which is just the topic, cardiac disease kills more women than breast cancer. Yeah. And we have all the pink ribbons and we need more red ribbons.
So I say, if I can leave, sorry to interrupt, but if I can leave with something, I always say this, and I actually got it from a mentor of mine. I want to be as good as the breast cancer campaign for cardiology. You're right. Heart disease kills more women than all cancers combined. It is the number one killer. 2 out of every 3 women has heart disease. 1 out of every 3 women will die from heart disease, and 90% is preventable. Let that sink in. So what do you do about it? How do you advocate for yourself? Know your numbers. You need to know your numbers. Blood pressure, cholesterol. You need to know your family history. You need to move. The simple things that seem simple need to be done. You need to get good sleep. Life is stressful. To reduce that stress and to be actively reducing it on a daily basis. To eat well, and the best way to be eating is in a Mediterranean style, that it has the best data behind it. It is the only, I hate using the word diet because it has so many negative connotations, but it is the only diet or way of eating that has been shown to reduce morbidity and mortality. And to move your body, because if you don't move it, and that sedentary lifestyle is a killer. And so those are the questions you want to come into with your doctor. What's my blood pressure? Where does it need to be? What's my cholesterol? Where does it need to be? Do I need imaging? This is my family history. This is my personal history. This is what I've experienced. What can I do to prevent that heart attack and stroke moving forward.
Well, I even had a problem with imaging because my doctor, before my insurance ended, said I want to get a CT scan, but I'm allergic to CT scan contrast. So I set up the appointment, and they wouldn't do it. They said they wouldn't cover. If I'm allergic, they wouldn't do the imaging.
Benadryl? They wouldn't cover the Benadryl?
No, they wouldn't. They wouldn't.
Yeah.
I was very confused by all this, but I can't get imaging because I'm allergic to. I had terrible hives last time I got a CT scan.
But did you ever get the non-contrast one, just the CT coronary calcium?
No, nobody would let me do that. They want only the contrast one. And now I don't even have a doctor anymore. So
well, maybe offline we can talk because
okay,
some things that I would recommend.
Okay, good. Let's talk offline. But thank you so much for speaking with me.
Of course.
What I'm going to do is I'm going to end the recording. It's going to end our conversation.
Okay.
I will call. I will come back and make another invitation so we can chat a little bit more at the end of this.
You can click on that Zoom I sent you.
I'll click on the Zoom. Let's go on Zoom. Okay. Thank you, Dr. Bakir. It's so great talking to you. And I know this conversation will help someone. Oh, I have one more question. I just realized.
Yes.
Should women in menopause find a cardiologist? And if so, what are they looking for?
Yes. So the American College of Physicians, the American College of Cardiology, and the American College of Obstetrics and Gynecology years ago said that every 30-year-old should have a primary care physician, a cardiologist, and an OB if a female. But of course, that didn't happen because of exactly what you were talking about, access to care. Even when you have an acute issue, you can't get in to see a cardiologist in a time. My wait list when I was in the traditional system was 16 months.
Oh my gosh.
16 months for a triple book 10-minute visit. And my visits with patients are never 10 minutes. And so it was. Okay.
So women listening to this, get yourself a cardiologist.
Yes.
Make sure they know something about women's health. Yeah. All right. I'm going to end the recording and I'm going to go back on Zoom to talk to you in a second. But thank you, Dr. Bakir. I really, really appreciate it.
My privilege. It was so
okay.
Talking.